So we're going to talk about switching ART. I chose this background for the slide because often when we're in clinic and trying to think about a switch, it feels like a puzzle. It feels like we're trying to gather all the pieces, and we may have some missing pieces, and we're trying to piece it all together. And it's pretty. So the first thing when we talk about switching ART is why are we switching? So what are reasons you guys have switched people?
Weight gain.
Mutations, resistance.
Mm-hmm.
Pregnancy.
Hep B.
Yeah, okay. That was a pretty good list. And yeah, I really think of it as two different categories. There are the people who are virally suppressed that you're switching for some other reason, all those things you guys mentioned, CKD, Hep B, pregnancy. And then there's the people who are failing, the resistance mutations. And those in my mind are two very different ways of thinking about it. So we'll start, so we're sort of divide the lecture into those two groups, and we'll start by talking about switching when people are virally suppressed. In practice, we do this far more often, I would say, these days than switching because people are failing. And so whenever we switch, these are our big goals. We want to make sure we maintain viral suppression with whatever regimen we put them on. We want to make sure we're maximizing their quality of life and minimizing adverse effects, right? That's pretty straightforward medicine. So these are just to highlight the main reasons why we're often switching when people are suppressed. Pill burden is a big one. We're often, if people aren't on one pill once a day, we're often trying to figure out, do they have to be on multiple pills? And it's not just, because it's nice for patients to take one pill. There's a lot of studies showing that one pill once a day regimens have higher adherence and better outcomes, better viral suppression over time. And financially, there's also the point that people are paying copays per medicine, per pill. It'll be cheaper for them potentially. That could be debatable. We also see that people, a lot of our patients have lower health literacy, polypharmacy from other reasons. It's a lot easier to get mixed up if you have multiple pills you're taking than just one single pill. Adverse effects are the other ones. GI intolerance. We don't see this a ton, but we do see it. There are patients who tell you that they just couldn't tolerate some medication. It really upset their stomach. It probably happens with the regimens we currently use, probably most often with our PIs that have the boosters with them. Other reasons are side effects, like neuropsychiatric side effects. Efavirenz has depression, and it has a high warning for suicidal ideation. It can increase the risk of that. Dolutegravir. This can be more subtle, but there are reports of headaches, insomnia on people on dolutegravir. The other one, one of you mentioned weight gain associated with TAF and some of the integrase inhibitors. So these are when your patients are telling you that they've, especially if it's in the short term since they've switched regimens, that they are having side effects, make sure to look up whether it could be related to your meds. Drug-drug interactions become a reason we switch to. The boosters are probably the biggest issue. Ritonavir and cobicistat, they inhibit cytochrome P450, and so they interact with a lot of different medications. The biggest ones, or the most common ones we come across in clinic, are steroids, especially systemic steroids, but also intranasal steroids can also be associated with an interaction leading to unsafe steroid levels. Statins, we're often making sure we're giving them the right statins. Rilpivirine has an association with PPIs. Rifamycins, I think Anna mentioned, when people are diagnosed with TB, we often end up switching their regimen because some of our favorite HIV meds don't work well with our rifamycins. And then another big drug-drug interaction we come across is with cations, especially like multivitamins, things like that. We'll see that people may impact the absorption of the instance. Next reason people switch is comorbidities, renal function. You guys know this. There's renal function. You can sort of think of a few ways. Is it renal function because of what we have them on, like particularly TDF, our old tenofovir version, or is it just our aging HIV population gets CKD for a lot of reasons? And are you guys familiar with some of our drugs block tubular secretion of creatinine? Have you guys seen this before? Come across this? So our boosters, bictegravir, dolutegravir, they can lead to, when you switch, they can lead to a small increase in creatinine. It's not actually a change in renal function. It's because it blocks the secretion of creatinine. So if you switch and see a small change, that shouldn't be concerning. Osteoporosis, Hep B, hyperlipidemia. And then cost. I mean, we don't see this a lot in the health department, I would say. Generally, what we prescribe our patients are able to get, but you know, if your patient can't actually afford and buy the med, they're never gonna take it. So those are the big reasons we're often switching. When you guys come to me and say, hey, my patient's on Biktarvy and I want to switch them to Juluco, what am I going to ask you guys? Why? Yeah. But I think we've seen this in clinic where you guys come up to me with that statement.
You need to know their Hep B status.
Yeah, I'm going to want to know their Hep B status, so some of their comorbidities. What else am I going to want to know about them?
They're undetectable.
Yeah, and they're in general, right? Their history of viral suppression, and what regimens they've been on before. So prior ART history, so, you know, what have they been on before? How did they do on those? Were they switched because they were failing? Were they switched because they were having side effects? Were they just switched for convenience or cost or something like that? Do they have any known resistance? So I'm always asking you guys what their resistance shows, and we're always digging through the chart. Comorbidities, you guys got to, these affect our choices, renal function and Hep B being the biggest things. And then potency of regimen is a pretty important topic to consider when switching. And when we talk about potency, we're talking about high versus low barrier to resistance. So our ART agents that have a high barrier to resistance need more mutations to develop resistance to them. It's harder to get resistance to them. If they have a low barrier, it's easier to get resistance. So which of our meds have high barrier to resistance?
Dolutegravir. Any most of your integrase inhibitors.
Not all of your integrase inhibitors, though. Bictegravir is generally lumped with dolutegravir in our high barrier. What about raltegravir, elvitegravir? So they're not considered high barrier to resistance. And then what's the other class that's generally high barrier to resistance?
Protease inhibitors?
Protease inhibitors. So in our current practice, that usually means boosted darunavir. So really high barrier to resistance, and this is going to come up over and over. You want to remember those ones: darunavir, dolutegravir, and then bictegravir, though it has less data overall. And then RTIs as a whole have a lower barrier to resistance. It's easier to get mutations, get resistance to those. And our earlier integrase inhibitors, raltegravir and elvitegravir, also have a low barrier to resistance. So when you're switching someone, if you're switching from one of those low barriers to high barriers, you're probably good. You're switching them to sort of a better med, basically, for their HIV generally. You usually don't have to worry too much, assuming you don't have some weird resistance profile. But if you're going the other way, if you have someone on one of these and you're switching them to something that's a low barrier, that's when we get a little more concerned about, is there any hidden archived resistance? Is there something we're missing back there? Are they, you know, is their adherence intermittent, and with their high barrier to resistance med, they're fine with that, but if we switch them to something else, is that going to become a problem? So you also notice that people with concerns about adherence, we often have on those high barrier to resistance meds. And when we're simplifying, one of the big topics lately has been 2-drug regimens. And so I meant to cover this to make sure you guys knew what these were. So if you didn't read that already, what are our 2-drug regimens? And yeah, so I heard dolutegravir, rilpivirine is Juluca. Cabenuva is what? Yep, and then what's the last one? Dovato. And what is Dovato? No, you wouldn't have 2 in our team.
Comorbidities is correct.
Yeah, there you go. Remember, it's always like dolutegravir.
Yeah.
So these are the approved regimens, and in general, if you're considering a 2-drug regimen, you want to obviously know that they're not resistant to one of those 2 drugs. you want to make sure at least one drug has a high barrier to resistance. So that's why dolutegravir is often in these. These don't work for Hep B, and there's some other caveats in there, but those are sort of the general principles. If you're choosing a 2-drug regimen, you want to be really sure those 2 drugs are working. And then there's also, people have looked into monotherapy, like keep looking at in terms of HIV, like we used to always do 3 drugs. Now we can get away with 2 active agents, Is there any way to just get away with 1 agent? If you're using dolutegravir, high barrier to resistance? And the answer is no. I mean, you guys can see the chart, but basically the monotherapy is that red arm. And at like 6 months, it was looking not awful. But then by the time you get close to a year, it was almost 10% of people were not virologically suppressed anymore. So obviously you would never want to do this.
Do those same people become resistant?
And a fair number of them had, a proportion of them had documented resistance. Yeah.
So
Yes.
Oh.
So you burn down dolutegravir. You don't want that. Yeah. And at the end of all this, I have a few cases we can talk through that are like real patients and where we've considered switching and what to think about. So that's sort of switching to optimized therapy when virologically suppressed. And then the other category is when people are failing. And so we talk about this all the time in clinic, right? When people have a detectable viral load, we're always thinking why. And in your guys' experience, what's the most common reason?
Non-compliant.
Yeah, not taking it, right? For either, because they didn't want to, or because they can't afford it, or because they couldn't, get a ride to pick it up, or they're homeless and someone stole it from them. There's lots of different things. And so usually you want to make sure you're thinking sort of systematically about the different factors that it could be, why people aren't getting enough, effective drug into their body to treat HIV. And so the patient adherence factors are, the social determinants of health are huge. And then the other things, maybe adverse effects, tolerability. If they tell you every time I took that pill, I got sick and I threw up, so I stopped taking it, like, fair, we should find them something else. HIV related factors are, more of our resistance. So knowing that they have resistance, either transmitted or acquired. You guys know how many people at the time they get HIV get a transmitted mutation?
It just depends on
Like a guesstimate of the percent.
10, less than 10.
It's somewhere in like 10 to 20-ish range, depending on the study. Often, and usually it's not integrase or PI, it's usually NRTI, NNRTI mutations. But that's why we get a genotype when people start to know about any transmitted resistance.
Sorry.
Yeah.
So when the state HIV program, they track the baseline resistance, and when they start tracking and the data is at least 5 years old, we don't have additional information. But in our community, it's between 7 to 10%. So generally, it's lower than the rest of the country, and most of them has been 184V mutation and some of the NNRTI mutation. But if you go to South Florida and things like that, then it will be a lot higher.
Thank you.
Is that percentage going up? Because I would imagine that the vast majority of your non-compliant patients are probably the ones that are going to accumulate the most in mutations because they've been on and off regimens so many times. So if they're the ones in the population who are potentially the spreaders as well, do we see that population of inherently like transmitted resistance going up over time, or is it pretty steady?
I haven't seen that. Have you guys seen that?
No, and I think that's partly because often the people transmitting are not on therapy and intermittently here. They're often just not on therapy. And when you're not on therapy, we have slides that show this, but the wild type virus tends to proliferate.
Okay.
So that's what's being transmitted.
I see. So the vast majority are either people who are diagnosed and never treated or people that just don't know they have it.
Yeah.
Gotcha. Okay.
Yeah. And then this is sort of a side note, but I said, we don't worry about transmitted integrase resistance. There is some concern that we may start seeing more integrase resistance at diagnosis and entry into care with our long-acting cabotegravir for both PrEP and treatment. If people are not adherent, could there be more, subtherapeutic levels of integrase in people that leads to resistant virus. Sort of a side note, but something to watch in the next few years. And then the last one is, the last group is ART regimen related factors. So things like pharmacokinetics, are they not absorbing? Are they taking it with their cations and their, multivitamin, and that's affecting the absorption? Drug-drug interactions, especially ones that would impact the level. Food requirements, PIs are technically supposed to be taken with food, though we don't, many people do just fine without paying careful attention to that. And then when we're talking about detectable viral loads, I think it's important to make sure we're all on the same page with the terminology, because there are sort of official terms. And so under 20, non-detectable, they're suppressed. This one's easy. Admitting people. And so there's a graph there, but it's pretty straightforward. And these graphs, most of the figures in this come from the University of Washington HIV curriculum, which is a really great resource. Certainly explore it. And then a blip. So you guys have definitely seen this in clinic where someone's been suppressed, and then they have one reading that's, 50 or 70. So a blip is when you have a single reading between whatever your level of detection is and 200. We don't do anything in this. In all of these situations where you detect viral load, you should address the things we talked about that can affect your viral load. So make sure they're taking it, their adherence, all of those factors. Make sure they don't have med interactions. So look into all of these. And then this is we see this a fair bit. So when someone has low level viremia, this is when your viral load is 20 to 200, and it's not just one time like the blip where it goes back to being suppressed, but it just sort of lingers in that range. So what do you do about this? Yeah, well,
It's not enough to send out a genotype or anything.
Yeah, you'll never pick it up.
You won't. It's too low on a normal genotype. So there is no full consensus, but generally the treatment guidelines say when you're at this level, there's a low risk of developing resistance. Guidelines say you just keep them on the same regimen, but you follow them pretty closely. You make sure you're checking viral load every 3 months to make sure it doesn't take off at some point. You always address adherence. You want to make sure they're taking it, and that's not the reason why we're seeing this. Interactions and potency of the regimen. And then if you're on a low potency regimen, so if you're on L-vitegravir as your integrase, maybe you consider switching in that case. Otherwise, generally not recommended to switch. There's no evidence that adding more drugs or switching regimens actually helps.
For transmissibility, what would your advice to somebody with a virologic blip or a long history of recurrent blips or the low level viremia? What would you tell them regarding condom use?
Yeah, so the studies for U equals U define suppressed as under 200.
Oh, okay.
So technically, all of those groups we've talked about, the blips, the low level viremia, would have qualified for the study.
I see. Okay.
Sometimes if you're talking to the partner as well and the partner's a little hesitant, you can sort of understand that too.
Yeah.
But generally, they would fit into the studies that were done that showed no transmission. And it used to be defined at 200 because that was as good as our test could get. Just over the years, our tests have gotten better. So some of these categories like low level viremia didn't exist in the past because we couldn't detect that low. And then virologic failure is when you cannot maintain a viral load under 200. So there's two different categories that sort of fit. The first one is just, failure. It looks like people were suppressed and then their viral load starts coming up. And then the bottom one is incomplete virologic response. Just if you hear that term, this is someone who's newly started on HIV meds and then they just never get suppressed. And so we're going to talk more about virologic failure the rest of the time. And in all the guidelines, they sort of break it down into whether your viral load's 200 to 1,000 or greater than 1,000. And do you guys know why they break it down into those categories?
For
genotype testing?
Yeah, that's basically the only reason they do is because above 1,000, you should definitely be able to get genotype. Below 1,000, you may or may not be able to. But basically, you manage them in the same way. Either way, they're failing therapy. And so you're going to address the causes of virologic failure, those causes in the top corner that we talked about. So you're going to talk to them about all those things. Are they taking it? Other meds? Yada, yada. And then if your viral load is greater than 1,000, you get a genotype and you see resistance, you're going to create a new regimen, right? I mean, that's pretty straightforward. What about if you don't see resistance? Everything's pretty strongly worded where if your viral load is above 1,000 and you're not seeing resistance on the genotype, it's an adherence issue. Yeah, or an absorption issue. Mm-hmm. Exactly. There are, yeah, ways to objective measures. Because you're just not, if you're not seeing resistance and there's not the selective pressure to choose a resistant strain. And so I just think that's interesting because your discussions with patients often are not as straightforward as this suggests. And just using a genotype. So this is another figure from the University of Washington HIV curriculum, but just reviewing when the best time to get a genotype is. So this is a patient with HIV. All those ugly brownish goldish dots are like wild type. And then there's one or two little like resistant strains. HIV replicates very rapidly and gets a lot of mutations if you're not on treatment. So when you put someone on therapy, you know, their total viral load is going to decrease. They have a lot less virus in them. They have less wild type and maybe a small amount of resistance. But then if you start having adherence problems, then you start getting all sorts of different little strains of resistant HIV. And there's more and more of them over time. And then, but if you stop, then generally those resistant strains are less fit, less able to replicate than your wild type strain. So when you stop that selective pressure, you end up with the wild type coming back. So your best chance of detecting resistance is to get a genotype while people are having their adherence problems, but still have that selective pressure from their antiretroviral regimen. And usually, things say between 4 to 8 to 12 weeks, you'll end up in that final panel where it's mostly wild type back. And important things to know about genotypes is that they can't detect every mutation. It has to be in enough of the strains. Usually they say about 20% of the strains to be detected. So if you had just like one dot that was a color, you probably wouldn't even detect it. But the virus keeps all these mutations inside the person. They're all still there. We say they're archived. They're sort of hidden out. You may not detect them, but once a mutation is developed, it doesn't just disappear ever. And that's why we always want to know their full history of resistance panels, genotypes.
And you said the time frame to going from the time where we have a better chance of detecting resistance to where the wild type proliferates and predominates is, you said 4 weeks.
4 weeks. You may detect more up to like 8 weeks, 12 weeks, but 4 weeks, you generally want to get it, that genotype while they're on therapy or within 4 weeks of stopping.
Okay.
And you certainly don't want to tell them to like stop and then come get their genotype
Right.
in a couple of weeks. Like you want to get the genotype that day.
So no matter what, there's always wild type, regardless of where you're at. Like
based on this chart, yeah. Yeah, I think there must be because it's the most fit and it always comes back.
Yeah. So basically,
so I guess so.
If you're off therapy, the resistant can't replicate as well without the pressure.
Yeah, exactly.
It kind of comes back and does its thing.
Exactly. That wild type is always seems to be the most fit.
Mm-hmm.
Okay. But it archives the previous mutations.
Yep. Fascinating, right?
So then if you're out of the window to detect that mutation, then they come back, and would it be useful to just put them back on therapy, see what happens, and then check a genotype to sort of?
Yeah, that's a great point. So there's the guidelines even get to like if you have someone who's had a lot of adherence issues, what do you do when they come in and they've been off? And it says one option, but it's sort of the only option they really give, is to put them back on their regimen. Especially, you would certainly want a high potency, like high barrier to resistance drug in that regimen. You put them back on that and then check a genotype or a viral load and a genotype if needed, like pretty quickly, like 3-4 weeks. You don't let them go very long.
And then if they're not suppressed, you can
And then and then if they're not suppressed, hopefully then your genotype might be more helpful. So that's why we're often asking about, like, why did they stop previous things? Was it because they failed? Because even if we didn't catch anything on a genotype, like, were they actually failing that med or were they not? And it matters because we don't always detect everything on genotypes.
So if you can't get a genotype, maybe you'll get to this, and you're less than 1,000, do you just guess what regimen to use? Do you stop them and then like get a genotype in a couple weeks?
Yeah,
Already
you never really just stop completely because that just gives a chance for the virus to just proliferate, and it won't be with any pressure.
Okay.
So I think that is such a dependent on the patient in front of you. Like, is it someone who you know has struggled with adherence and they're on a bunch of other meds and you're wondering if maybe they mixed up their meds and haven't been taking it? You know, it very much depends on your clinical sense. Do you try to change something now or do you try to keep them on their regimen and follow up in a couple weeks, like really closely? And it's really a patient discussion at that point.
But if they're like being consistent with their antiretroviral therapy, but they're still just like kind of in that.
Yeah. So if they're truly resistant, you would think they wouldn't stay at like 250 viral load over time. They'd start going up.
Okay.
Right. So if you're following really closely, you should see a change in the trend. They shouldn't just be sitting.
Gotcha.
I would expect.
I can read the chat from Morsani.
Oh yeah, thank you.
There is a latency as well as source in the reservoirs. Helpful to notate the genotype it was on or off ART and switch to regimen.
And just, you know, when we're talking about the types of resistance assays, we're usually talking about genotypes and we're talking about the top one, which is the conventional genotype we always get. It's usually the most affordable. It's not an immediate turnaround. You guys have seen that. It takes a week or maybe longer in the health department to get our result. And that uses sequencing to identify the drug resistance mutations and then correlates those with known resistance profiles. You may have to order your integrase genotype separately. It's not always included. We talked about it usually requires a viral load of 500 to 1,000 or more, and it's best when you obtain it while on ART. There's also proviral or archived DNA genotypes. I haven't personally used this very often, so if anyone else has, I welcome your input, but it looks like cell-associated proviral DNA and PBMCs, and you can perform it even when you have very low or undetectable HIV levels, and it can identify archive mutations potentially. Everything I read sort of said clinical utility, it may be helpful. It's unclear how comprehensive these are, if they catch everything, but if anyone's used them, I welcome any comments. Or Dr. Morano, if you have any thoughts, feel free to chime in.
Hi, team. Yeah, no, great talk. I didn't want to interrupt the flow. Yeah, so the I think it was called ultra deep sequencing. It was done a lot at Yale in the early days of HIV. And it's interesting. I think it was really done when we didn't have a lot of ART choices, right? And we really had to know granularly what people's resistance were. And at that time, there was a lot more transmitter resistance because people weren't, perfectly suppressed, mainly because the regimens were hard to take and there weren't many options. But yeah, no, you're absolutely right. We don't do that much anymore, mainly because we don't have the resources and people don't do that much anymore in terms of academics. And we also have so many new choices, right? So we get the best we can, and the laboratories have gotten so much better. So our genotypes, commercially have improved. So I think for that, when we talk about archival genotypes, a lot of us will just go, back to the original genotypes on file and try to use that to extrapolate, right, what the resistance might be moving forward. But you're absolutely right. We don't use that much anymore for all those reasons. But they used to be very helpful and very necessary. But thankfully, we've kind of evolved away from those for those reasons.
Mm-hmm. Thank you. And then also used to be used more often in the past were the phenotype assays, where it takes the dominant HIV strain, so not all those less dominant ones, creates clones and tests for drug susceptibility. This used to be used in people who were very treatment experienced with lots of mutations to give a better sense of what actually worked when you tested drug against their strain, but only available from reference labs these days, I believe, and not common, but you may see it in our, especially in our, I don't know what the VA's charts look like, but in our health department charts, you may come across this, so good to know what it is.
Yeah, may I add?
Yeah.
I was growing up in that era when you used a lot of phenotype. So if you look in the chart, we asked the clinic to keep those paper in the paper folder, and when you look at it, it would call PhenoSense. It's usually the brand. When you see that, PhenoSense actually is a phenotypic assay. And when you see PhenoSense GT, they run both phenotype and genotype at the same time. We don't do it very often anymore. Sometimes you see some discarded as well. Back in the day, you might end up have to make decision. If even though the patient have genotypic resistant, but phenotypic is still working, you might end up using that drug because you have no choice. But you know, not really relevant for your practice nowadays.
At the VA, you may come across it in this imaging or JLD when you're looking for genotype and you find a phenotype. But again, probably you're not going to find any recent phenotypes in any of your VA patients.
Yeah, this is Jamie. Can I just add real quick? This is a great conversation. So in terms of VA and phenotypes, absolutely. And for the same reasons, we used to have the genotype, which is the objective, right? And then the phenotype is really how it works in the wild, right? Or how it works, in real life. And so what we noticed is that when we had people who didn't suppress, right? Who were on a regimen, it seemed like they would suppress based on the genotype, but in actuality, they weren't. Sometimes we used the phenotype to see what it was going on with the drug interactions, right? Because remember, genotypes will give percentages of function. So it's not a binary, 0 and 1 that the drug works or not, right? So you can have 30% efficacy, at some types and that kind of thing. So yes, we actually don't, that I know of, send out phenotypes in VA. We try to see how they do on the genotype alone. But you're right, it used to be very useful, but since we have better regimens and better laboratories, we usually do the genotype, and you can put that in the Stanford database. We can talk about that end, and that tells you it's like a rough phenotype of how that's actually functioning in the body, and we can go over that later. But thank you.
So the general principles of creating a new ART regimen. First is that our goal is always viral suppression. Again, sort of everyone else's points. It used to be in the past we couldn't always get everyone virally suppressed. You do your best you can. With our current meds, we really aim for viral suppression in all. You really need to know their history. Their resistance is cumulative for all the reasons we mentioned. You always need at least 2 active meds, preferably 3, but we know that a lot of times 2-drug regimens can work. And if a 2-drug regimen, you want to make sure you include a high potency med. Don't forget about hepatitis B. That's always a big one that can really cause issues. And you don't want to add 1 drug to a failing regimen. And we have some case studies at the end that will look at the Stanford database and other things too. The guidelines, when you read them, give you some second line options for depending on what your failing regimen is, if that's your initial regimen, and then what you could consider switching to. So there's all these lines. You can read it, lots of abbreviations. The summary is basically you will choose darunavir or dolutegravir when possible. Potentially bictegravir as well, but it doesn't have quite as much strong evidence behind it for these resistance cases. That's really the summary. You want to be on one of those 2. And I thought I updated it. It used to say if you were failing one of our newer integrase inhibitors, bictegravir or dolutegravir, they weren't sure what to recommend. Now it says, go to darunavir or And then if they're failing a second line regimen, the first advice is basically the same. You can use protease inhibitor, your darunavir, or one of your good instis, use those. If you can't use those, then leave at least 2 or ideally 3 active agents. And there are patients who maybe had failed multiple regimens, but then you look at what they were on, they've had HIV for a long time and they were on a lot of older drugs. So maybe every once in a while we still get someone, especially people who've moved from out of the country, who have never been on an integrase inhibitor or never seen it. So you probably have a good chance you're going to be good with that one. So we still see it. And then there's a bunch of sort of more salvage-ish regimens that have different mechanisms of action. Ibalizumab, which is a CD4 post-attachment inhibitor. It's given IV every couple weeks. Fostemsavir pill. Lenacapavir is another long-acting. It's injection every 6 months. So obviously none of these you'd use on their own, but they could be part of a regimen. But usually if your patient's very resistant, you also may be looking into like investigational research studies for highly drug-resistant HIV. And then a sort of related topic that we come across is this is not virologic for failure, but some patients we see poor CD4 recovery even when virally suppressed. We usually see this in people who, started really low. Like we had someone at TGH recently with like 0,
Yeah.
CD4 cells. So if their CD4 count is really slow to recover, we won't be shocked. It often takes a long time and it can take years. It can continue increasing for years and years. But some people just never fully recover. So this is often the patient will be asking you and you'll be wondering, like, is there any benefit to switching regimen? Should I do something about this? And basically, no. If they're virally suppressed, so we know that their persistently low CD4 counts are associated with increased morbidity mortality, even among those virally suppressed. But people have looked at this, and there's no evidence that adding an additional antiretroviral agent or switching classes actually improves the CD4 recovery. So it's one of those, it doesn't feel great. But people do get switched sometimes just to see, but there's no real evidence for doing that. Okay, so we're gonna go through some, I don't know what time it is, it doesn't tell me, but. Okay, so we have time, okay.
I think for these people who are like persistently low CD4s, this is probably a weird question. During acute illness, have they ever given or maybe before, like a clonal stimulating agent to try to bump up their counts before?
Not for a T cell?
Yeah, is there something that they tried? It's probably a weird question.
Yeah, I can answer that, Jackie, but go ahead.
Yeah, no, you go for it.
Yeah, no, that's a great question. And thanks. And Dr. Sherbuk, this is a great presentation. So interesting you said that, because in the early days of HIV, there are actually studies of that with ART, and they said that it wasn't really efficacious, but they did actually early Neupogen studies. So the answer is no. I mean, the bone marrow is so suppressed, and what's going on is there's such illness. So yeah, no, it was not long-term effective, and I think it was not even helpful for their immune recovery. And if I can just add really quickly, sometimes if you have really low CD4 counts, we've seen this in the VA setting when people are transferred to our ID service, sometimes you can take them off Bactrim and their CD4 counts started recovering. Remember, Bactrim can be myelosuppressive. So we switched them to atovaquone and they started coming up. So yes, hopefully that answers your question. But yeah, no, they tried. It didn't work very well. Really just suppressing their virus is really the best and trying to help their immune system other ways.
Thank you, Dr. Morano. Okay, these cases are not board review style questions. They're just real life cases that we've seen in the past couple months since I started thinking about this. So, Jess, do you want to read it?
Sure. Manny's been taking his once daily regimen of efavirenz and emtricitabine TDF since he was diagnosed with HIV in 2007. Loves that he's been remained virally suppressed on this regimen and has declined change of start in the past. Today he tells you he has been experiencing many life stressors and noted worsening depression. His viral load is suppressed. He moved from out of state and you have been unable to track down his prior records or genotypes. What is your recommendation?
So what's the brand name for that regimen? Atripla, the first, triple 3 drugs in 1 pill regimen. Yeah. So what are your guys' thoughts on this one?
He's underwent a lot of life stressors. We can't just chalk it off to the efavirenz. Who wants it to?
So what does worry you about efavirenz and mood?
Depression.
And then more particularly,
suicidal
ideation. Yeah. So what would you recommend? Would you keep him on it? Would you switch him?
There's no multiple choice.
There is none. This is real life. These are real life cases. This is just, what are you going to do?
Assess him for suicidal ideation.
Yeah.
Okay, good.
You have a gun. You have a gun.
Yeah. Good job. We have.
That's legit.
Yeah.
And if I'm not too worried, I can maybe start like SSRI or something.
Would you switch his ART?
You might consider. First question is like when if it's driving his depression and potential suicidal ideation, how rapidly do they see improvement when they get off the drug?
I don't have a great answer. But.
I'm just kind of curious because I'm like, well, if you take him off the drug and he gets better, it happens rapidly and he gets better rapidly, it's probably the drug as opposed to life stressor because that's not going to go away very quickly usually.
Yeah, just to add on your question.
Yeah.
A lot of times, if patient on the drug for a long time,
Yeah.
the drug is not the only thing that causes a problem. But when the problem starts, it gets really bad.
I see.
So generally, when you take off the drug, patient feels better in a couple of weeks. Remember that the efavirenz had pretty long half-life as well. But then underlying mental disorders is gonna need to address.
Sure.
Yeah. So in this case, I'd switch him at this point with the concern for suicidal ideation. Also, you know, a lot of our older regimens, he's on the older tenofovir. I didn't include an age, but if he's been diagnosed with HIV for this long, he's probably getting older. You know, the TDF version has more effects on the kidney and bone. So I would say it. And then the other thing, just comment about, we see this a lot with the last line in his case where he moved from out of state and you've been unable to track down prior records. In his case, if you know someone has been on the same regimen since they were diagnosed,
they're still suppressed.
Yeah, so he's probably fine. He's never been exposed to a protease inhibitor and integrase. The virus was transmitted before we even had, you know, much in the way of integrase. So you're probably fine switching from that standpoint. Okay.
Hey, Jackie, this is Anthony.
Yeah.
This is, again, you're pointing out something very astute at the beginning. Notice on the boards, nobody is going to use all these ridiculous trade names that we use when it comes to HIV regimens in the clinic. Okay, you will see exactly what Dr. Sherbuk has denoted here in her case presentation, and then looks like they're, you know, later on in all her cases. So again, when you hear, you know, you see all these crazy names, gloppity gloop, whatever they call these things, you have to know the generic names of the drug, what's in it for the combination. Yes, it's important to know it for the patients because that's how they know it and how most HIV providers communicate that stuff these days. But when it comes to boards and brass tacks, you have to know what's in the pill. That's my tuppence on this issue.
And Dr. Cannella, I have a feeling I'm going to disappoint you in one of these cases. It might have slipped through.
It's okay. It's just, but it is important to note that, because again, I like I just told some of the fellows, I'm doing the longitudinal knowledge assessment deal now because I refuse to do that stupid 10-year test. And you know, and I'm doing questions every, you know, throughout the time of a 90-day period. And I can tell you that they do not have, you know, Joluca or whatever, and all these silly names that everybody uses. They have exactly what you're denoting here for a triplet. So just keep that in mind for the fellows and for the junior faculty who are going to start doing LKA and these things for your ABIM. You will see this, and you will have to remember what's in the regimen because it's you know, we use these things every day in our practice. Oh, okay, it's, you know, it's this or that, but it's not that. The pill has 3 different components, or 4 in terms of some other meds. So just keep that in mind when you're studying for these tests. That's about my only point. Sorry.
No, this is Jamie. Can I just add? I think that's a really great point. And traditionally, we do teach in generics. So thank you for that, Dr. Cannella. I just want to also add the good news also in the VA space, particularly, we do use the generics in the med list. So that's another obviously good reason for trainees to understand, you know, right away to have that really good basis for generics. Because when you're even, you know, looking at the medical records, obviously that's what's going to pop up for good reason. So thank you for that point and that confirmation.
There's just one case of one more comment, if I can make, too, with a patient like this in case 1, is sometimes you really have to have a conversation with them about whether or not they want to switch. I mean, this is a patient who's been on therapy, the same therapy since 2007. A lot of times those patients say, Doc, I've been on this therapy for, 15 or 16 years. I'm sure it's not the drug. Please try maybe some other interventions before we switch because I'm very comfortable with this regimen. So a lot of times you have to convince them, yeah, it may be this, it may be making it worse. So consider a switch, but sometimes you really have to get the patient involved with the decision.
Yeah, and in this case, in real life, he was had been one of those who was always like, nope, it's working for me, I'm staying on it. creatinine had been creeping up over the years. We'd been like, hey, they eventually need to switch. And so this sort of prompted this, a new reason, and he was open to switching. But exactly to your point, we end up with that discussion a lot.
Adding to that, good history taking is vital, because they're very hesitant to switch, as we've noted. So they'll say they're fine, but then it's a little bit more subtle. It's like sometimes you have to ask, are you having any vivid dreams? Are you having any nightmares? It's particularly with the efavirenz, are you feeling foggy? And then I've had patients actually tell me, no, I love the vivid dreams. And then they'll tell you their mood is fine, but they're following with psych. So really read those mental health notes, really go dig deeper with stuff.
I have to add funny story. One of my patients, when marijuana was not such a thing, his work had to do during drug screening regularly. He refused to be off efavirenz because it also has false positive for urine drug screen, and he would come in and ask me to write a letter on efavirenz.
Oh man, I already surprised with a little bonus.
Can confidently say that's probably a positive.
See if that starts.
Joe, do you want to read the next one?
Sure. Joe is a 55-year-old man. He was diagnosed with HIV in 2007. He's been on dolutegravir and Truvada for many years and tells you he has always been well controlled with an undetectable viral load and CD4 greater than 500. He'd like to simplify his regimen. He has CKD. What is your recommendation?
Why? And what is it? Yeah. And why do you guys say that one?
One pill and he's got CKD.
Yes.
So this probably be good for him.
What else are you going to need to know before you'd consider switching to
Hep B.
Right. Yeah, I mean, this is one of the most common situations we have where someone, whatever their regimen is, their CKD, with our aging population, we see this a lot where we have to start adjusting regimen. And so, yes, dolutegravir, rilpivirine is really nice because you don't have to dose adjust anything. If he has Hep B, then what are you thinking?
Dolutegravir, lamivudine. I mean, yeah, no.
Yeah, then it's not going to be a simple answer. Usually, if there's CKDs to the point where you can't use, like, creatinine clearance less than 30, you can't use a lot of our one pill once a day regimens, then it starts getting tricky. So I don't have if anyone has a great, easy answer, I would love to hear it, but often it gets more complicated at that point.
Yeah.
This is Jamie. Can I just add, because I think that was an important point raised by the fellow. Lamivudine, of course, is Hep B active. It's just not as active. It's not considered first line for suppression anymore. So I think that was a great point and something the boards might trick you on, right? So even though it's Hep B active, if he's Hep B or core positive, you have to really be careful. I think you really do need a TDF agent. You can also, of course, add entecavir if you're, if you're really kind of have a little less options, right? If you have kidney problems. So that's also something that's possible.
Although the dosing for both entecavir and our tenofovir gets tricky
Yes.
with low renal function.
Yes. Yes.
So, yes. Okay. Next case, Arun, you want to read?
Carlos is a 55-year-old man. He was diagnosed with HIV in 2015. He has been on dolutegravir and Centuza for many years and tells you he has always been well controlled with an undetectable viral load and CD4 greater than 500. He'd like to be on a single pill regimen. Review his genotype from when he was diagnosed. It showed an M184 mutation. What is your recommendation?
So before we get to the answer, since I neglected to write it out, what is Centuza? What's in it?
Darunavir.
TAF, FTC, and booster.
Yeah, they're with the booster.
I looked it up.
Yeah. So what do you guys know about the M184V mutation?
Interesting.
What about intracidity?
Resistance.
Resistance. What else?
Makes it a less fit virus.
Okay. Yes. What does it do with tenofovir?
It makes it better.
Yeah, it hypersusceptibility. So M184V, you get high level lamivudine and emtricitabine resistance, but increased susceptibility to tenofovir and decreased replication capacity. So what does that mean in terms of this guy's regimen and if it's possible to go to a single pill?
Good candidates.
Yeah, so a lot of people have looked at this because say you wanted to go to our old favorite Biktarvy. How many active drugs would you have? Two, right? Because the emtricitabine in there would be resistant. So people have looked at this because a lot of people actually have M184V mutations, whether or not it's even recognized at the time when they do sort of the deep sequencing and stuff in clinical trials, they find like a fair number. So this was a big study where they looked at 2,000 people in their clinic that they had switched to Biktarvy. When they went back and looked, 10% of those people had M184V or I mutation. And they looked at how many people stayed virally suppressed regardless of that mutation. And basically viral suppression was excellent, whether or not people had it. So this is one of many studies that are out there at the moment. I mean, they're generally like retrospective or pulling from a clinical trial of switching. There's tons of clinical trials out there switching to new agents as they come out. But then they mine it for secondary studies. And so for this one, they showed that at least in people who are virally suppressed at the time of switching, they did just fine on Biktarvy. So I think in this case, I would be fine letting him be on, Biktarvy if he wanted that single pill. We used to, before we knew so much about it, that's why a lot of people you'll find who are on dolutegravir or Simtuza, there was some resistance, and that's why they're on dolutegravir, darunavir, and 2 NRTIs. They're on a lot of drugs because there was some resistance seen. So that's when you really need to know their history. Did they fail regimens? What exactly was their resistance? Or was it something like this where maybe they don't need that full regimen?
So I just want to add, Dr. Morano posted the chat. She said because bictegravir has excellent binding capacity, thanks for including.
I have a question about the mutation. When you say that it has increased susceptibility to the tenofovir, is that only in the presence of emtricitabine or just in general?
So, yeah, so if you don't, because this virus, part of that M184V makes it decrease replication capacity, so it's less fit. If you don't have emtricitabine, then you remove that selective pressure. And so you no longer, so then you wouldn't, your wild type might outcompete. So a lot of people will actually keep the TAF or tenofovir emtricitabine combo because that emtricitabine keeps the pressure on and makes the tenofovir more susceptible because you're keeping that strain of virus around that is more susceptible to tenofovir. So even though you know that emtricitabine isn't,
doing anything
necessarily doing anything, it's sort of secondarily doing something.
I read that.
Yeah, it's really interesting, actually. And they usually come together, so it's not like you're giving the patient extra meds anyway. Okay, Yuri, you want to read this one?
Yes. James is a 63-year-old man on darunavir, COVID, TAF, FTC, and dolutegravir since 2019. HIV RNA over the last years have been 70, 120, less than 20, 70, 140, 120. CD4 ranges from 250 to 350. He misses 2 to 3 doses per month. Prior ART regimens have included lopinavir, boosted lamivudine, TDF, raltegravir, the danosine, Regataz, stavudine, bioresistance panels show M184B, K103KN. He would like to know if his ART regimen should be changed due to low-level viremia. He is otherwise tolerating his regimen well. What do you recommend?
And so what's the brand name for his first drug?
Simtuza.
And his mutations, the M184V we just talked about, what class is K103? I heard efavirenz, so the NNRTIs. Okay, so what do you guys think about this?
It just seems like he's chronically low level viremia.
He's missing doses. So.
He's missing doses. Probably could explain why.
Yeah. Exactly. Yeah. This is someone where you're really like, we have our pharmacists and at the health department to do adherence counseling. This is where you really want to try to access all your resources because he's missing doses. He's been undetectable on this regimen, but then he bumps back up and down, and you don't really know how much that is the missed doses versus just low-level viremia. And so you really want to work on adherence. You want to work on, is he having any intolerances? What can you do to make this easier for him? But like Jess was saying, based on what we covered, there's no indication to change regimen. And I also don't know exactly what you would empirically switch.
Right, exactly.
So you're sort of, exactly.
The time you're on boosted and 14 different meds.
Right, and you probably aren't going to give him something with a novel mechanism if you know he's already missing doses.
Yeah.
You'd be a little concerned. You probably just leave him be, but extensive counseling. Okay, Anna?
Gina is a 38-year-old woman with HIV. She has been taking raltegravir plus TDF and emtricitabine for many years. She tells you that she takes ART intermittently when she doesn't feel well.
Yeah.
6,500. CD4 count is 250. You get a genotype including integrase. It shows a Y143R mutation.
So what's that mutation?
Is that integrase?
Good job, Will. Yeah. So this is one of those where, Dr. Morano alluded to earlier, the Stanford database. Have you guys all seen that in clinic at some point? So this is it. You do first that box up there. It's sort of in a weird order, but you go in and you enter all their mutations. And then it gives you a printout by class of the different classes and the different drugs and where there's predicted resistance, high level, low level, susceptible. And then it gets even more involved where it will give a score for agents with partial activity so that you can try to use those scores to group together enough agents to have an effective regimen. But so for this mutation that she got while on raltegravir, and raltegravir is high or low barrier to resistance? Low, yeah. It shows that there's low-level resistance, or there's high-level resistance to raltegravir, potential low-level resistance to elvitegravir and cabotegravir, so don't give her that. But it's susceptible to dolutegravir and bictegravir. So in this case, you have the option to still use those agents, obviously with a lot of counseling and very close follow-up. Yeah, but we've all seen those patients. We see them. They come back to TGH every month despite our best efforts. So yes.
And then what is the top part? So you have the box where you actually put the mutations.
Yeah.
Top part. Where do you have to put
this?
it? No, the middle one. Yeah. Do you
So these just say results will be shown for the checked ARVs.
Okay.
So and those are basically all of our current ones we would use. The things that are unchecked are older agents that we would never be prescribing. So I just leave it at what it defaults to. And then I just copy paste here. And then you get this nice printout. And it would also give you, if you entered other things, it would give you your reverse transcriptase the same way. So this is a wonderful website. There are other ways to look at mutations, but this one I feel is just so easy and practical. And it also sometimes gives you a little comments, which is even nicer. Like these Y143 mutations are associated with high-level raltegravir resistance. Alone, they have minimal effects on elvitegravir susceptibility. However, they're associated with intermediate reductions in elvitegravir susceptibility when they occur in combination with one or more accessory integrase resistance mutations. It does not reduce susceptibility to dolutegravir, bictegravir, cabotegravir, but that sort of contradicts. Well, I don't know about that one, but in general, it's really, really helpful website. So this is one to stay aware of. Okay, Will?
Bobby is a 53-year-old man with HIV, schizophrenia, seizure disorder, CKD, diabetes, who has been on a regimen of dolutegravir/rilpivirine plus TAF/FTC for a few years. Other medications include Haldol, Cogentin, Depakote, Seroquel, metformin, atorvastatin, clonazepam. Lives in a group home and his sister helps with doctor's appointments, medications, routine labs for your visit with Bobby show an HIV RNA of 11,000. He has previously been undetectable for years. His CD4 count is greater than 500. What do you do?
Some drug interactions. Lots of potential.
Yeah, so I hear
Pharmacist.
polypharmacy, I hear genotype, I call involve your pharmacist,
DDI.
talk to him, right? You know, this was a real patient who like try to sort out, and in his case, talk to the sister too. You're trying to sort out what is going on. So you talk to the sister, the patient. They say this was just, you know, his routine pre-visit labs. They say, oh, no, we haven't changed anything. No change in his other meds, no change in his HIV meds. We have no idea. So then we involve the pharmacist. And, you know, he's on a lot of meds. It seemed like somewhere in there, maybe a fill got missed. Maybe the pillbox or whatever system he uses didn't get filled with the HIV meds. And so in his case, genotype didn't show anything. No, there was a multivitamin added. We adjusted that. But he restarted his meds and we rechecked in a couple of weeks and he was suppressed again.
So he was missing his meds accidentally.
So it was just an accidental missed meds. It's just going back to not every viral load is because they're resistant, though of course that's always what we worry about and we always evaluate for it. You also have to like really dive in depth into all the other things going on with the patient. And in this case, everyone still insisted he had been taking it the whole time, but he got virologically suppressed again and we went with it.
Just a comment, I mean, if you're checking viral loads regularly and you see kind of a progression in the viral load upward, that's different from somebody who was fully suppressed and then the next time you check, they're up at 11,000. That is more likely to suggest non-compliance or some error with taking the medication rather than virologic failure, in my experience.
Yeah. Thank you. That's really important. Yeah, you expect that trend is so key.
This is Jamie. I'm so sorry. Can I add something? This is a really good case.
Yeah.
I think that's a great case in point, and we see that a lot in assisted living facilities where they're getting the wrong meds or not enough and that kind of thing. I just also wanted to point out I mean, it wasn't as relevant in this case, but the dolutegravir, of course, right, can increase the serum concentrations of metformin, and I believe it interacts with the valproic component. So it looks like, you know, valproic products can decrease the serum concentration of dolutegravir. And why I mention that is this patient appears already at risk for maybe not, being as responsive to dolutegravir as he could have been. So you're right, any change or aberration in the ART dosing will kind of change that balance. So thankfully he was still suppressed, but the valproic products do have an interaction, I think. So just something to be aware that, yeah, you're right, he didn't have a lot of room for error there. So great case.
Yeah, thank you. There's one or two more cases. Jesus?
Brandon is a 26-year-old man diagnosed with HIV 8 years ago. He's had a history of intermittent adherence over that time. You see him at TGH for recurrent esophageal candidiasis. His HIV RNA level is 60,000. His CD4 count is 18. He most recently was on some Tuza. You are concerned that he may be developing resistance from poor adherence. What art do you start?
You maybe
check a genotype and have a follow-up.
How long has he been off? Because do you run the thing that you had mentioned where it kind of reverts back to wild type? Is it going to give you a genotype that's more based on that rather than any actual resistant pattern he has? So would it make more sense to put him back on the Suntuza, and if he doesn't suppress again, then you get a genotype?
Yep. Yeah, that's basically exactly that.
Okay.
This is a viral at a 60,000 with him off for some period of time. My questions are not perfect here, but and exactly for what you said, he's gonna at this point probably the genotype will show mostly wild type. That we'll get a genotype, you know, to see. And we sort of talked about this earlier. People have just been off. You often restart, especially when you're starting a medication. This Cetiza has darunavir, high barrier to resistance. It's pretty hard to get resistance to darunavir, though it's possible. You need multiple mutations. And then you follow up really closely, and in a few weeks you check a viral load with a genotype. Make sure there's not something hidden there that you're now selecting for with the pressure.
So then would you, if, let's say dolutegravir would be an option for him, would you wait to start that later, or would you?
Yeah, and this is not a clear, there's no one right answer to this. Some people, I've seen people get started on like a darunavir plus a dolutegravir plus the, TAF emtricitabine or something. People end up on multiple agents. So there's different ways to go about it. Yeah. The key is going to be eventually you have to choose something with the information you have, and then you follow up really closely with a genotype and a viral load if they're not yet suppressed. Okay, this was the last one. Gerard?
Tommy is a 43-year-old man with CD4 counts of 386. He took the antiretroviral regimen, efavirenz, tenofovir, emtricitabine, and did well on this regimen for about 18 months with persistently undetectable HIV RNA levels. Subsequently, he had a 6-month period of poor adherence, and his HIV RNA level increased to 2,320 copies. A genotype is performed and one significant mutation is identified, K103N. No other mutations are reported. What regimen do you recommend?
So what's KO103N, which class?
NNRTIs.
Yeah.
So then would he be a candidate to maybe start like a dolutegravir or something like that?
Yeah. Yeah, so there's, again, no one right answer, but you would avoid the NNRTI class with the K103N. You would take him off his AAA he's on. Guy.
This is a fantastic question. Okay. I know you don't see a lot of this anymore because we don't use efavirenz a lot.
Yeah.
Yeah. So why is so this is like signature mutation, blowing efavirenz. Why does this person lose that and not have another mutation? And it's something about the pharmacology of the drug.
The long half-life?
Super long half-life. And so you basically have 2 of the 3 drugs have a much, much shorter half-life than the other one. So if you take it intermittently, you're having just these low levels of efavirenz hanging around for a long period of time where it's the only thing there. And that's how you get mutations in HIV. Like this is, and they're giving you the signature mutation for it too. So this is a perfect question for boards.
It's too.
Yep.
Yeah, it's actually in the purview that we went through.
Yeah, and so there's, and you'll notice when you do board review for resistance questions or HIV ART questions, it often includes older regimens that we don't see as much. So it's important to sort of practice those and get a little more familiar with some of them. And like I was saying, we don't use this regimen as much, at least at the health department. But I think the sort of corollary is what I mentioned earlier with our long-acting injectables now in terms of the risk of having these like low levels, below therapeutic levels of like cabotegravir, and whether we'll see more resistance in the future related to that if people are not adherent with their dosing schedules. So I think that's the end. Yeah, the end.